to this section we're going to be talking about the ventilator. And in particular, there are a couple buttons here that we will probably want to review, being hyperoxygenation and muting the alarm. But first off, before we go any further, just a disclaimer, as you guys, as students in the clinical settings, your hospitals may not want you to touch the ventilator. If that's the case, then of course follow those policy and procedures and let your nurse know if the alarms are going off on your ventilator. However, again, the oxygenation and mute buttons are two that we're going to go over. Those are some important things that we have on our ventilator. Again, also you'll be in theory courses be going over the different settings for your ventilator and the different types of patients we might use for those. So this is again just an overview of how we might take care of a patient and how we might use the ventilator or the suction setup. So just before we go any further, let's go ahead and talk about the ventilator. Alright, and now we're taking a look at the ventilator. We have our screen here. As a student, as a nurse, we aren't going to be dealing a whole lot here on the screen. We do notice though that on the bottom portion here on this ventilator for this manufacturer, we have a list of settings, being the ventilator mode. This F is standing for frequency, which might be representative of rate on different ventilators as well. Tidal volume, represented by this capital V, subscript capital T. Then you have your PEEP, which is 5 over here, and your FiO2, which is currently 100%. So these are different areas of settings on the ventilator that I might look at as a nurse, just to review those settings for my patient. But again, I'm not responsible for actually changing these settings. That is something your RT or your doctor does give you orders for the RT to do, or the doctor themselves. Now, as far as buttons that we would be pushing, hyperoxygenation. So as you guys have probably all read, or maybe a reminder for you, hyperoxygenating our patient. When do we do that? Anyone want to take a guess? Give you a couple seconds. Good guess. So we're going to suction when we're going to suction our patient, or maybe when we're repositioning or turning our patients. So this hyperoxygenate button, which is represented on our ventilator here in the sim lab as 100% O2/cal 2 minutes, that's hyperoxygenation. It pops open this little box over here. We can see that there's a timing bar that's going to be progressing as our 2 minutes completes. And once that's done, it'll automatically shut off. So we don't have to worry about coming back to the ventilator and hitting that button again. It'll automatically shut off for us. So again, we'll do that whenever we suction, whenever we're repositioning the patient, or you see that that patient's having a little trouble breathing and that oxygen saturation is a little low, then we'll go ahead and press hyperoxygenation. All right, so we're going to cancel that alarm now. And the second one is muting the alarm. Again, as students, a reminder, if your hospital says do not touch the alarm and mute those alarms, please follow that practice. Just because as students, we may not know what alarm went off, so to be safe, we just want to make sure that RN lays eyes on that alarm. All right, so that mute one, though, is here on the left. What happens is for 2 minutes, it will silence all of these alarms. However, that means that patient could be disconnected from the ventilator and alarms going off. So that's not good. We could have the patient biting down on the tube, preventing oxygen and air from going into the patient's lungs or getting out, which will cause high pressure alarms. So these are all different reasons why an alarm might go off. The more and more you start working with them, and the more you work with your respiratory therapist, the better understanding you will have. So if you guys are at clinicals, definitely ask those respiratory therapists about the ventilator, and I'm sure they'll be more than happy to give you guys some more information. Alright, so now that we're taking care of our patient who is intubated, we want to make sure that we understand different parts of an assessment for this type of patient. So when I come in and I have a patient that's intubated with an endotracheal tube, meaning one of these that goes through the mouth into the trachea, I want to make sure I know where that endotracheal tube is, and that means position. Landmarks are what I'm going to be using, and those are actual physical landmarks on my patient. So that does not mean that I'm going to use this anchoring device. So this anchoring device, you can see on the outside, this blue part, it's plastic. I can read a physical number right outside of here, and it's about 20 right now, right at that point where I have on this plastic piece. The reason I don't want to use this anchoring device for my measurement is because it could be moving around. And so what's happening on the inside is this tube is moving around. So let's say that my patient somehow wiggles free, and this device comes out. As you can see, this device is out. However, if I say that it's measuring 20 at this anchoring device, it still measures 20 at this anchoring device, but it's not 20 inside the patient's throat, right? So when it was into the patient, it was in the right position, it was right above the carina, and we were getting full ventilation on both sides of our lungs. But when we pulled it out, or the patients pushed that tubing out, it's now in the incorrect position, and we have to put that back. What happens in this event? We have to call our RT and let our doctor know. We as nurses aren't going to be pushing this tube in. We don't readjust. Just because it came out a couple of centimeters does not give us the right as an RN just to shove it back in. We have to make sure we call the RT, call our doctor, let them know what the situation is, and then they'll give us orders and allow the RTs or the doctor themselves to reposition this tubing. And again, we also want to make sure we get a repeat chest x-ray as always, just to confirm where is the end of this tube, where's the end of this tube in our carina. All right, second part of that is, so like I said, it was 20 at the lip at the anchoring device, and in reality, it's about 18 at the lip line. So when I give a report, I'm going to say your ET tube is measuring 18 at the lip line. The second part of this information is I want to know the size of my endotracheal tube. And so there's two sets of numbering systems on these tubings. You'll see one that says it's a little bit of a bigger font, and it's just these Roman numerals, or not Roman numerals, just your alphanumeric numerals. It says 22, goes to 24, 26, 28, and there's a little triangle above it. So those are the ones we use for measuring the distance, how far it's in to our patients. And there's this tiny, tiny, tiny little number, and it says 7.0. That's the size of our endotracheal tube. That is what I want to make sure that I record. So in the event that my patient has a trouble, let's say they get extubated, they pull it out by themselves, well, I already know now what the size of the endotracheal tube is, so if I have to get a new one, I can go grab that in the case of an emergency, and I'm all safe. All right, great. So we have that out of the way. One thing I also want to review with you guys is inline suctioning. So let's try that in one sec. Okay, so we're going to do some inline suction now. You might notice a little difference with my hands here. I've got some gloves on. So of course, while we're dealing with our patient and we are doing some inline suctioning, we'll always want to have our gloves on. So let's start with that inline suctioning process. We are already going over testing the suction. So just actually doing the inline suction portion, we're going to grab this, again, that T-piece that's really stable for us. Grab up here at the beginning of our inline catheter, suction catheter. You see it's very flimsy. We're going to start grabbing it there and start feeding it into the endotracheal tube, short strokes, real fast and quick. Nice and smooth and consistent, straight into the patient. Once I get in there, we do on and off intermittent suctioning, right? ATI, 10 to 15 seconds, ring a bell, and rotate. You can try and rotate, but you might notice that there isn't a whole lot of rotation going on. So, a reminder for you guys, while you're reviewing those inline suctioning videos, I'd encourage you to go back and look. Were they suctioning with an inline suctioning case, or were they doing the one that was free-flowing, the one that did not have that over there? So if they were doing that, most likely it was with a trach, but there is a slight difference, but I want us to make sure that we notice the differences in these types of devices that we use. But go ahead and try and do it one more time. So again, I'll show you as a demonstration. I'm holding to the T-piece. Feed that through really quick. Got that in there. On and off, intermittent suctioning, 10 to 15 seconds. As a rule of thumb, if you want to use that 10 to 15 seconds, great. Also hold your breath, because if you cannot breathe or you're getting short of breath while you're suctioning, most likely your patient's getting suctioning. So that's always a practice element that I carry with me that I received from my clinical professors. Okay, so that suctioning process is done. Also, one thing to be mindful is while I am pulling the catheter out, I'm holding on to this T-piece here very tightly and pulling it out. We do not let go and just pull on the end of this suction catheter out. If I just do this, I am pulling on the tube. It is unstable. I could actually remove this tube from the patient. So make sure you keep your hand on here at all times, all right? Great.